Good morning to all of you. Once again, welcome to the teaching class of Department of Urology, Savai Mansingh Medical College, Jaipur. Today, we have a class on testicular tumors, and this would be presented by our resident, Dr. Mohammad Faijal, and would be moderated by our faculty, Dr. R.D. Sahu. So I would request Dr. Faijal to please share his presentation. Dr. Mohammad, go ahead.
Yes, sir.
Full screen, please. Yes. Okay, perfect.
Yes, sir.
Go ahead. We can't hear your voice.
Okay, sir.
We can't hear your voice.
Hello, good morning, sir.
Little closer to the mic, please.
Yes, sir.
Closer to the mic. Go ahead.
Hello. Good morning, respected teachers, seniors, and dear colleagues. Myself, Dr. Mohammad Faisal. I'm here to present seminar on the topic of testicular tumor. And my moderator is Dr. R.D. Sahu, sir, Assistant Professor, Department of Urology, SMS Medical College, Jaipur. First, come to the introduction part. Morphologically and clinically, a testicular tumor is a very diverse group of tumor, and this diversity is because of difference in natural history, pathology, and treatment of the tumor. More than 95% of which are germ cell tumor, which is further divided into seminoma and non-seminomatous germ cell tumor. Germ cell tumor is relatively a very rare malignancy, 95% of which arises from the gonads and 5% are extragonadal in origin. WHO classified germ cell tumor derived from the germ cell neoplasia in situ and germ cell tumor unrelated to germ cell neoplasia in situ. The tumor which is derived from the germ cell neoplasia in situ includes seminoma, non-seminomatous germ cell tumor, embryonal carcinoma, yolk sac tumor, choriocarcinoma, and teratoma. And the tumor which is unrelated to germ cell neoplasia in situ includes spermatocystic tumor, prepubertal type of dermoid cyst, epidermoid cyst, mixed teratoma, and prepubertal type of yolk sac tumor. The sixth core tumor includes Leydig cell tumor, Sertoli cell tumor, granulasa cell tumor, mixed sex core tumor, and some are still unclassified. The germ cell tumor per se, the epidemiology, the testis cancer is the most common malignancy among the age group of 20 to 40 years of age, and second after the leukemia in age group of 15 to 19 years. Their incidence rises rapidly after the puberty, peak at the age of 25 to 35 years of age, and declines after 40 years of age. The incidence of bilateral germ cell tumor is approximately 2%. These are usually metachronous, and the difference between the two tumor is average of 5 years. And the histology of the two tumors may be different. The incidence of testicular malignancy in the United States, they are 3.6 times more common in white than in blacks, 2.5 times more common in Asians. These days, their diagnosis at localized stage increases from 55 to 68%. This is because of widespread use of ultrasonography. And only about 13% of the men are initially with distant metastatic disease. There are certain risk factors, 5 are well established of them. Number 1 is white race, cryptorchidism, family history, personal history, and germ cell neoplasia in situ. The germ cell neoplasia in situ is characterized as referred as a precursor lesion for all the germ cell tumor except few. When we are talking about the cryptorchidism, it is 4 to 6 times more common in the ipsilateral testis and 1.74 times more common in the contralateral testis. For family history, if the history of tumor present into the father, then it is 2 to 4 times higher chance to develop malignancy. If it is present into the brother, then 4 to 8 times higher chance to develop the malignancy. And if you are talking about the personal history, it is 12-fold increased risk. The most of the germ cell tumor arise from a precursor lesion called germ cell neoplasia in situ. The few exceptions which are still which are classified as spermatocystic tumor, prepubertal type of dermoid cyst, ovarian cyst, and prepubertal germ cell tumors. There are some histological variants. First are germ cell neoplasia in situ. 80 to 90% of the tumor has germ cell neoplasia in situ in adjacent normal parenchyma, and 5 to 9% of patients have germ cell neoplasia in situ in the contralateral normal testes, which increases up to 36% if it is associated with testicular atrophy or cryptorchidism. Germ cell neoplasia is much less frequent in pediatric age group. The second one is seminoma. Seminoma is the most common type of germ cell tumor. It's peak into the 4th or 5th decade of life. Grossly, they are soft in consistency, tend to white in color, diffuse or multinodular in appearance. Histologically, they are sheets of cells, polygonal nuclei with clear cytoplasm. They also have 15% of the cases, they also have syncytiotrophoblasts, which is responsible for the beta HCG release. And they stay negative for CD30, positive for CD117, and strongly positive for placental alkaline phosphatase. They are considered to be common precursor for the other type of non-seminimatous germ cell tumor. The next one is spermatocytic tumor. This is a rare malignancy, less than 1% of all germ cell tumors, and it's peak into the 6th decade of life. Unlike other germ cell tumor, spermatocytic tumor does not arise from the germ cell neoplasia in situ, is not associated with cryptorchidism or bilaterality, and does not occur as a part of mixed germ cell tumor. And they do not stain for OCT3 and 4, placental alkaline phosphatase or glycogen. They are usually benign tumor and almost always cured by orchiectomy. Embryonal carcinoma is the most undifferentiated cell type of non-seminimatous germ cell tumor, resembling primitive epithelial cell from early stage embryos. They grossly they are tanned to yellow neoplasm, has areas of hemorrhage and necrosis. They also have syncytiotrophoblastic cells. That's why they are also positive for beta HCG. They have totipotential capacity and has propensity to differentiate into other type of non-seminimatous germ cell tumor, including teratoma, within the primary tumor site or at metastatic sites. They stain positive for AE1, AE3, placental alkaline phosphatase, OCTN4, but never for c-KIT. Choriocarcinoma is a poor risk tumor, usually diagnosed at late stage, and their poor prognosis mainly because of the non-pulmonary site of metastasis. More common of them is brain. Choriocarcinoma commonly spread by hematogenous route. Microscopically, they have syncytiotrophoblasts, cytotrophoblast, and syncytotrophoblast is strongly positive for beta HCG. They are prone to hemorrhage, sometimes spontaneously, sometimes immediately after starting of the chemotherapy. They are also associated with some hormonal disturbances, such that hyperthyroidism, elevated androgen production, and hyperprolactinemia. This is because of alpha subunit of HCG is homologous to the receptor present on the thyroid stimulating hormone and luteinizing hormone. The yolk sac tumor, pure yolk sac tumor are more common in the mediastinal primary and pediatric germ cell tumor, and less common in the adult gonadal primary and retroperitoneal germ cell tumor. Yolk sac tumor may grow in glandular, papillary, or microcystic pattern. They have characteristic feature of Schiller dual bodies in almost 50% of the cases. And their other characteristic feature is eosinophilic hyaline globules present in 84% of the cases. They can be present into the intracellular or extracellular location. Yolk sac tumor almost always produces alpha fetoprotein, but not HCG. The teratoma, the tumor that contains elements of at least 2 of the 3 germ cell layer, that is endoderm, mesoderm, and ectoderm. They are further classified into mature teratoma and immature teratoma, but there is not clinical significance. Teratoma is a Greek word which means monster tumor. Normal tumor, their serum tumor marker are normal, but sometimes elevated alpha fetoprotein level are noted. Teratoma is resistant to chemotherapy. That's why surgical treatment is the primary mode of treatment. But sometimes teratoma may grow uncontrollable, invade surrounding structure, and become unresectable. For serum tumor marker, yolk sac tumor secretes alpha fetoprotein, choriocarcinoma and seminoma secretes HCG, and embryonal carcinoma secretes both. The clinical presentation of the testicular tumor, the most common presentation is painless testicular mass. However, pain can be present, especially in the non-seminimatous germ cell tumor. This is because of the high vascular nature and rapid growth. Patient may have history of testicular trauma. Trauma just draw the attention of the patient towards the tumor which is already present. They can also be present with the weight, scrotal discomfort, or heaviness. In approximately 2% of the men have gynecomastia. And this is because of raised level of HCG or estrogen, and more common with the Leydig cell tumor. Although approximately 2/3 of the men with germ cell tumor have diminished fertility, it is an uncommon presentation. 10 to 20% of the patient initially present with the symptoms related to the metastatic disease as a presenting complaint. For example, palpable intra-abdominal mass due to retroperitoneal lymph node enlargement, palpable neck mass due to involvement of the supraclavicular lymph node, dyspnea, chest pain, cough, or hemoptysis due to pulmonary metastasis, and lower extremity swelling due to involvement of inferior vena cava. Their differential diagnosis includes epidermolysis, torsion, hematoma, and paratesticular neoplasm. A firm intratesticular mass should be considered cancer until proven otherwise and should always be evaluated by scrotal ultrasound. If your presumptive diagnosis is epidermolysis, give a course of antibiotic and re-evaluate the tumor after 2 to 4 weeks after completion of the oral antibiotic. If swelling is still present, go for the repeat ultrasonography to rule out the malignancy. Diagnostic testing, scrotal ultrasound nowadays considered an extension of the physical examination because of their widespread use, easy availability, non-invasive nature, high frequency transducer, even small lesion in few millimeter can be detected. Typical presentation of germ cell tumor on ultrasonography is hypoechoic. Seminoma has homogeneous ecotexture. Non-seminomatous germ cell tumor has heterogeneous ecotexture. And increased flow on Doppler is suggestive of malignancy. But if there is not increased flow, then it does not rule out the malignancy. Presence of a small impalpable scar or calcification indicates burnout primary testis tumor. And seminoma is one of the most frequent subtype of germ cell tumor which undergo spontaneous regression. Serum tumor marker level, alpha fetoprotein, beta HCG and LDH are included in the TNM staging of the testicular cancer. An increased level of the LDH denotes the tumor bulking. Patient suspected of having germ cell tumor should have blood drawn for serum alpha fetoprotein, HCG and LDH before archectomy. It helps to aid in the diagnosis to help interpret post-archectomy tumor marker level. In patients whose disease burden is such that required urgent treatment, even substantially elevated serum alpha fetoprotein level or HCG level may consider sufficient for the diagnosis of germ cell tumor. Patient with pure seminoma in the primary tumor with an elevated serum alpha fetoprotein level are considered to have non-seminomatous germ cell tumor in it. The role of sperm cryopreservation, 52% of the men have oligospermia at the time of diagnosis, 10% are azoospermic, and almost all of them will become azoospermic after chemotherapy. This is because of general epithelium is highly sensitive to platinum-based chemotherapy and radiation therapy. The recovery of spermatogenesis after radiation therapy for seminoma may take 2 to 3 years or more. And retroperitoneal lymph node dissection may result in ejaculatory dysfunction in 80% of the cases. Men who are planning for future pregnancy are recommended to undergo sperm cryopreservation before treatment is initiated. Clinical staging based on histopathological finding, pathological stage of the primary tumor, serum tumor marker level, and extent of the metastatic disease, which is determined by either physical examination or imaging. The initial management is radical or high inguinal archectomy. It includes removal of the tumor-bearing testicle and spermatic cord up to the level of internal inguinal ring. A transscrotal archectomy or biopsy is contraindicated because it leaves the inguinal portion of the spermatic cord and may alter the lymphatic drainage of the testes, which increases the risk of local recurrence, pelvic or inguinal lymph node involvement. The role of testis sparing surgery, it is highly controversial and has no role if contralateral testis is normal. But it may be considered in some cases, for example, bilateral testicular tumor, which is synchronous, and solitary testis with the tumor, and the tumor size is very less than 3 centimeter, involving less than 30% of the total volume. Intraoperative frozen section is necessary, and additional biopsy from adjacent tissue should be taken to rule out germ cell neoplasia in situ. As discussed earlier, 80 to 90% of the patients with germ cell tumor have germ cell neoplasia in situ in the adjacent normal parenchyma. If germ cell neoplasia in situ comes out to be positive, low dose radiotherapy can be given. It prevents the development of germ cell tumor while preserving the Leydig cell function. The role of contralateral testicular biopsy, as discussed, 5 to 9% of the patients with germ cell tumor have germ cell neoplasia in situ in the contralateral normal testis. It increases up to the 36% in case of testicular atrophy, history of cryptorchidism, and age less than 40 years. And contralateral testicular biopsy also considered in patient which has suspicious lesion on ultrasonography. Serum tumor marker should be evaluated before both pre and post archectomy. It helps in staging, prognosis, and treatment selection. Newly elevated or rising tumor marker post archectomy indicates presence of metastatic disease, and these patients should be treated with induction chemotherapy. Spread of the tumor in choriocarcinoma, the root of spread is hematogenous, and most other primary lymphatic drainage to the retroperitoneal lymph node is the primary landing zone. For right testis, inter-aortic cable is first involved, followed by paracaval and para-aortic lymph node. And for the left testis, first involved are para-aortic lymph node, followed by inter-aortic cable nodes. And contralateral spread from the primary landing zone is common with the right-sided tumor, but it is rarely seen with the left side tumor. Staging imaging. CT imaging with the oral and IV contrast is the most effective method to monitor the retroperitoneal lymph node. And enlargement of retroperitoneal lymph node are found in 10 to 20% cases of the seminoma, 60 to 70% cases of the non-seminomatous germ cell tumor. If the retroperitoneal lymph nodal size is more than 10 millimeter, then it is considered positive. Less than 5 millimeter considered as negative, and 5 to 9 millimeter is equivocal and should be looked cautiously, particularly if they are anterior to the great vessels. False negative result of CT scan, especially in case of clinical stage 1 non-seminomatous germ cell tumor, is 25 to 35%. Almost all patients should undergo chest X-ray, and CT chest should be performed in case of elevated post-archectomy serum tumor marker level, if evidence of metastatic disease by physical examination, or abdominal pelvic CT is present, or abnormal finding or equivocal finding on chest X-ray, and clinical stage 1 non-seminomatous germ cell tumor because of high false negative rate. The TNM staging of the testicular tumor. The primary tumor is T. The T1 is the tumor limited to the testis and epididymis without lymphovascular invasion and involving the tunica albuginea but not the tunica vaginalis. In T2, tumor is limited to the testis and epididymis with lymphovascular invasion or tumor extending to the tunica albuginea with involvement of the tunica vaginalis. T3 is spermatic cord involvement and T4 is the scrotal involvement. For regional lymph node, N1 is retroperitoneal lymph nodal involvement. The size is less than or equal to 2 centimeter in greatest dimension. For N2, it is more than 2 but less than or equal to 5 centimeter. And for N3, it is more than 5 centimeter lymph nodal involvement. And for M1, it is further divided into M1A and M1B. M1A is regional lymph nodal involvement with pulmonary metastasis, and M1B is non-regional lymph node involvement with non-pulmonary metastasis such as brain, liver. And for serum tumor marker, it is divided into S1, S2, and S3. For alpha fetoprotein, the level less than 10,000, less than 1,000, 1,000 to 10,000, and more than 10,000 nanogram per ml is classified as S1, S2, and S3 respectively. And for HCG, less than 5,000, 5,000 to 50,000, and more than 50,000 million international unit per ml is classified as S1, S2, and S3 respectively. And for LDH, less than 1.5 type of the normal, and 1.5 to 10 times of the normal, and more than 10 times of the normal is classified as S1, S2, and S3 respectively. For staging, stage 1 is classified into stage 1A, 1B, and 1S. And 2 is classified into 2A, 2B, and 2C, and 3 is further divided into 3A, 3B, and 3C. For stage 1S, with any size of the tumor, with no nodal involvement and no metastasis, if tumor marker is positive, it is stage as 1S. And there are classification. International Germ Cell Cancer Collaborative Group divided the germ cell tumor on the basis of prognosis. This is classified into good prognosis, intermediate prognosis, and poor prognosis. Seminoma has no patient classified as poor prognosis, and serum tumor marker level is not included in the prognostic classification of the seminoma. For non-seminoma, mediastinal primary and non-pulmonary metastasis and serum tumor marker level S3 is classified as poor prognosis. For intermediate prognosis, testicular primary, retroperitoneal primary, and pulmonary metastasis and S2 level of the tumor marker is classified as intermediate prognosis, and testicular or retroperitoneal primary with pulmonary metastasis and S1 level of the tumor marker is classified as good prognosis. There are certain treatment modalities. The first modality is surveillance. Surveillance is done by clinical assessment, chest X-ray, serum tumor marker level, CT, abdomen, and pelvis. And the duration of surveillance is for first 3 years, it is every 3 months, for 4 to 7 years, every 6 months, and for more than 7 years, annually. The second modality is first-line chemotherapy, that is BEP regimen, which is B is bleomycin, etoposide, and cisplatin, and this cycle can be repeated every 21 days. The next modality is dog-leg radiotherapy. The name is because of the shape that area involved into the radiotherapy zone. It is covering the retroperitoneum and ipsilateral pelvis. The dose is 20 to 30 gray and 10 to 15 fractions given daily. Seminoma is the radio-sensitive tumor, but non-seminomatous germ cell tumor is highly radio-resistant. The next is retroperitoneal lymph node dissection. Conventional retroperitoneal lymph node dissection include the removal of all the lymphatic tissue included within the boundaries of bilateral infrahilar templates, plus resection of the tissue in the interiliac region inferiorly to the level of bifurcation of the common iliac arteries with the addition of suprahilar tissue bilaterally. The recent recent modifications are nerve-sparing retroperitoneal lymph node dissection, modified unilateral and bilateral templates. Now come to the stage-wise treatment. Stage 0 is germ cell neoplasia in situ. There are 3 modalities of the treatment. First is radical archaeectomy, second is low-dose radiotherapy, and third is close observation. Radiotherapy is avoided if contralateral testis is normal. Patient is planning for the future paternity because 40% of will require androgen replacement therapy in future. Seminoma, for stage 1 seminoma, surveillance is sufficient because 5-year relapse-free survival is 80 to 86%. Cancer-specific survival is 100%. If relapse occurs in retroperitoneum, go for the radiotherapy. If outside the retroperitoneum, first-line chemotherapy is the treatment of choice. For stage 2A and 2B, 15 to 20% of the seminoma fall in this group if the tumor size is less than 3 cm for the dogleg radiotherapy. If after the stage 15 to 20% of the seminoma fall in this group than 3 cm or relapse occurs post radiotherapy, go for the first line chemotherapy. If the tumor size is more than 3 cm or serum tumor marker is positive or multiple retroperitoneal lymph node involved, go for the first line chemotherapy directly. For stage 2C and 3, as per the prognostic classification, if it is comes under the good prognostic group, give 3 cycle of DEP regimen or 4 cycle of EP regimen. If it comes under the intermediate group, 4 cycle of BEP regimen can be given, and there is no poor prognostic group in seminoma. If there is post chemotherapy residual mass is present and the residual mass size is less than 3 cm, high dose chemotherapy can be given. If the size is more than 3 cm, go for the PET-CT. If PET-CT comes out to be negative, high dose chemotherapy is the treatment of choice. If PET-CT comes out to be positive, do post chemo surgery. If the histopathological specimen suggestive of malignancy, go for high dose chemotherapy. If post chemotherapy relapse occurs, it is divided into early and late relapse. If relapse occur within 2 years, it is classified as early relapse. If relapse occur after the 2 years, it is classified as late relapse. And the early relapse has poor prognosis. It has potential for teratoma at the site of relapse. Therefore, if serum tumor marker is negative, do a biopsy to rule out teratoma. If teratoma is present, surgical resection the treatment of choice. If teratoma ruled out, start second line chemotherapy. If relapse occurs late, for after 2 years, it has better prognosis. Surgical resection the treatment of choice. If tumor is non-resectable, TIP regimen is the chemotherapy of choice. For non-seminomatous germ cell tumor, for stage 1, it is highly controversial. First classified the tumor on the basis of risk factor for occult metastasis. If lymphovascular invasion is present on archaeectomy specimen, the chance of occult metastasis is 45 to 90%. If embryonal carcinoma is present, the chance of occult metastasis is 30 to 80%. For lesion more than T1 is also chance of occult metastasis is present in absence of any of the risk factor. Still 20% chance of occult metastasis is present. If tumor is low risk group, there is no lymphovascular invasion, no embryonal carcinoma, then surveillance alone is sufficient. For high risk group, the modalities are either surveillance, retroperitoneal lymph node dissection, or primary chemotherapy, 2 cycles of BEP regimen. For stage 2A and 2B, there are 2 options. If serum tumor marker is normal, retroperitoneal lymph nodal size is less than 3 cm, treatment of choice is retroperitoneal lymph node dissection, followed by plus minus adjuvant chemotherapy. If serum tumor marker is raised and retroperitoneal lymph nodal size is more than 3 cm or back pain is present, the treatment of choice is induction chemotherapy, followed by post chemo surgery. For stage 2C and 3, if on the basis of prognostic classification, if it comes under good prognostic group, 3 cycle of BEP regimen or 4 cycle of EP regimen is sufficient, and 5-year survival rate is 91 to 94%. If it comes under intermediate or poor risk group, 4 cycle of BEP regimen can be given. If lung are compromised, bleomycin can be replaced by ifosfamide, and high dose chemotherapy has no survival benefits. The role of adjuvant chemotherapy, it is decided on the basis of histopathological report. If it comes out to be N0 or N1, then there is no role of adjuvant chemotherapy. If it's come out to be N2, 2 cycles of BEP regimen can be given. If it's come out to be N3 or elevated serum tumor marker level or incomplete resection or there is lung nodule present, give 3 or 4 cycle of BEP regimen. The role of post chemo surgery. The post-chemo residual mass repeat serum tumor marker level restage the tumor by CT imaging of the chest, abdomen, and pelvis. There are 4 possibilities. Both serum tumor marker level and CT comes out to be negative, then it is classified as complete response. Only surveillance is sufficient in these cases. If serum tumor marker level is positive and in CT tumor size is also increased, then it is classified as disease progression and second line chemotherapy can be given. And if serum tumor marker is positive and there is partial response on CT, marker which is classified as marker positive partial response, in these cases also second line chemotherapy can be given. If serum tumor marker is negative and CT shows partial response, it is classified as marker negative partial response and post chemo surgery can be given. If histopathological reports comes out to the malignancy, this is followed by 2 cycle of BEP regimen. For relapsing tumor, if relapse less than 2 years, it is classified as early relapse, has poor prognosis. If relapse occurs after 2 years, it is classified as late relapse. For early relapse, second line chemotherapy, there are many regimen. TIP for 4 cycle, VIP for 4 cycle, VEIP for 4 cycle, and high dose chemotherapy in which cisplatin is replaced by carboplatin and includes ifosfamide. If after second line of chemotherapy relapse occur, serum tumor marker level increases. If resectable, if disease are resectable, go for the salvage surgery. If serum tumor marker level is normal but residual mass is present, do post salvage chemosurgery. If histopathological report comes out to be malignancy, there is no role of post-op chemotherapy. For late relapse, it has good prognosis. Most of the non-cementeous germ cell tumor are chemo-resistant, so do a biopsy to confirm viable malignancy. Most common is yolk sac tumor to rule out teratoma and malignant transformation. If yolk sac tumor is present, TIP regimen is the treatment of choice. If no yolk sac tumor, complete surgical resection can be considered. For brain metastasis, if detected prior to any treatment, 4 cycle of BEP regimen can be given. If after the chemotherapy, tumor mass is still present, resect the residual mass. If it occurs after the first line of chemotherapy, give second line chemotherapy. If after the second line of chemotherapy, residual mass still present, resect the tumor or go for the radiotherapy. There are some non-germ cell tumors. The 6-core tumor includes 90% of them are benign, 10% are malignant. Most common of them are Leydig cell tumor, which is 70 to 80% cases. The peak incidence is at the age of 30 to 60 years. The common clinical presentation is gynecomastia and precocious puberty. More than 10% of the all precocious puberty is associated with Leydig cell tumor. If the tumor size is less than 3 centimeter, testis surgery can be considered. It has a pathognomic feature of rinky crystals, but its role is still unknown. If tumor is malignant and it can metastasize to retroperitoneal lymph node, go for the retroperitoneal lymph node dissection. And this tumor is chemo and radio resistant. Sertoli cell tumor is less than 1% of the testicular tumor, peak at 45 years of age. It is associated with it has some syndromic association such as Peutz-Jeghers syndrome, Carney syndrome. It has no association with organism. If tumor size is less than 3 centimeter, go for the testis sparing surgery. The next one is granulosa cell tumor. It is most common testicular tumor in infant less than 6 months of age. If the tumor size is less than 3 centimeter, testis sparing surgery can be done. Now for gonadoblastoma, there is 40% chance of bilaterally, so treatment of choice is bilateral archectomy. Lymphoma, primary testicular lymphoma is very rare. It is mostly secondary from other extra testicular site. In men more than 50 years of age, non-Hodgkin lymphoma is the most common testicular lymphoma. 35% cases have bilaterality. The treatment of choice is radical archectomy. For dermoid cyst, onion peel appearance on USG is the diagnostic. Enucleation or partial archectomy is the treatment of choice. Secondaries can also be present into the testis from the prostate, lung, melanoma, colon, or kidney primary. Thank you.
Thank you, Dr. Faijal. So, in the meantime, I would request all the residents and faculty, those who want to give their comments or have any queries, please go ahead. For the benefit of residents, I will just briefly summarize. So, Testicular tumors, we know all are very important in two respects. One is the most common tumor in male, particularly the age group of, as you said, 20 to 40 years. And this is the most curable tumor. So it's very important that the tumors are detected as early as possible. So as we do a self-examination in breast for breast tumors, it is recommended that males, young males, they start examining their testes once they become adults or adolescents. And if they find any kind of mass, which is the commonest symptom, testicular, physician. When about the evaluation, as we all know, usually they will present with painless testicular mass. Sometimes they can present with pain in the lower abdomen, pain that may be one of the symptoms. And if they are metastatic, then their symptoms could be due to metastasis. To evaluate them, the most important thing is to do a physical examination and then also do a scrotal ultrasound to other lesions that can mimic testicular tumor, and then also do a scrotal and also to see the contralateral testes. We should always do CT abdomen and pelvis to know the metastasis in the abdomen, and an X-ray chest and tumor markers, alpha fetoprotein, beta HCG, LDH. So once we have done all these, then the primary diagnostic and both therapeutic for localized testicular tumor would be a radical orchidectomy. So once we do a radical orchidectomy, then the pathological specimen will help us in staging of the disease, which will depend upon the pathological histopathology of the tumor, plus the CT staging, X-ray chest, and the tumor markers. So then you do a TNM staging of the testicular tumors and then treat the patients accordingly. We all know it's very important to, particularly in cases 1S and above, which have metastasis, they can be stratified as by International Germ Cell Cancer Collaborative Group into good risk, poor risk, and intermediate risk. Seminomas, we all know, they do not have any poor risk. It's just a good risk and intermediate risk. So good risk patients would be those would again depend upon what? Would depend upon the histopathology, whether it is a seminoma, whether which type of histopathology is, the site, primary site, and metastasis. So if it is metastasis to the lymph nodes and lungs only, it comes under good risk. And if the LDH level is less than 2.5 times the normal, and if it is more than 2.5 times or the normal, or there is metastasis to other site than lymph nodes and lungs, it comes under intermediate risk. If the patient has any rise in alpha fetoprotein, or if the beta HCG is more than 1000, that it is treated as non-seminomatous germ cell tumor and not as seminoma. Non-seminomatous can be divided into 3: good, intermediate, and poor risk. Again, based on the pathology, the site of metastasis, if it is lungs and lymph nodes, if the alpha fetoprotein is less than 1000, less than 100 rather, right? And beta HCG less than 1000, then probably it comes under good risk. So similarly, this is divided into 3, as I said in seminoma. Poor risk would be if it is the alpha fetoprotein goes about 10,000, beta HCG goes about 50,000, I think, and LDH is more than thrice the normal. And if there is metastasis to the sites other than livers and lungs and lymph nodes. So this way, and the management, as we all know, the primary treatment is radical orchidectomy, and the rest of the treatment will begin from active surveillance to chemotherapy. So most of these patients, once metastasis, they will be treated after radical occluctomy by chemotherapy, as he has described. And some patients of seminoma in the stage 2 can be treated with radiotherapy, and non-seminomatous by RPLND. So after chemotherapy, if there is relapse, then again we know either do resection of the residual mass or start with salvage chemotherapy. So this is in a nutshell the management of testicular tumors. So if any comment, Nachiket, from your side, RD, anybody, and residents, do you have anything to say? Please go ahead. Just make the... How do we see all the thumbnails here?
Participants space.
Participants with it? Participants with, okay. Fine. I don't think there are many who have joined the link. Yes, Adi, please go ahead. Adi, you can come and just give you yes first. Yeah.
If the alphabet of protein is high, but on the histology it comes down to the seminoma, then we have to treat it as the seminoma, or we have to consider it as a non-seminoma.
Non-seminoma. That's what I'm saying. Even in histopathology, if it is seminoma, but the alpha fetoprotein is high, it has to be treated as non-seminoma. No doubt about it. Yes.
In high volume disease, if how is there any indication of giving the preoperative chemotherapy for forehead?
So neoadjuvant chemotherapy, the only role of neoadjuvant chemotherapy is in widespread metastasis, where the tumor, localized tumor, is extending through the spermatic cord into the abdomen, where if you do a radical occluctomy, you are trying to cut the tumor, right? In widespread metastasis with advanced local disease, that's the only indication for neoadjuvant chemotherapy first. Yes.
So patient with the one side, the left side, testicular abscess, and the other side, sonography demonstration of the microlithiasis, no clinical findings. Sonography demonstration of microlithiasis.
Okay.
Left side reverse total abscess.
Right.
40-year-old patient.
Okay. So 40-year-old patient, right side microlithiasis ultrasound says, and there's a left side testicular abscess. Right. So what do you ask?
So
How to manage? See, microlithiasis again is a debatable thing, whether this is a pre-malignant condition or not. There are studies which show that probably those patients who have microlithiasis on ultrasound, they are more prone to develop malignancy later. But till then, I don't think we need to do anything, just to keep them on follow-up, and not only on physical examination, but we may do a routine scrotal ultrasound to know whether if there is any tumor later, right? Anything else? Another thing very important is about the cryopreservation. Cryopreservation has to be done because these are young patients, and those who desire fertility, cryopreservation should be done before any surgery or any chemotherapy, right? Or any radiotherapy. So that is very important. Secondly, there is a thing called testicular carcinoma in situ. If there is a carcinoma in situ, then probably we can spare the testicles and do a local radiotherapy only in these patients. And now for a localized tumor, there are studies which show that testicular sparing surgery, as we do in non-germ cell tumor, this could be done in germ cell tumors also. If it is a very small tumor and we want to preserve the fertility, we might have an option for, particularly when there is a contralateral tumor also, we might save the other testes by doing a testicular sparing surgery. Anybody else? Nachiket, you have any comments? Okay, Adi, your last comments of the moderator, and just we will wrap up then. So,
just few 2 or 3 practical of importance point remain undiscussed. One is the how tumor markers are followed after post orchidectomy. So thank you.
When do you do that?
Sir, post-orchidectomy 3 to 4 months. Sir.
3 to 4 months? No.
And you
40 months.
24
4 weeks, 3 to 4 weeks.
4 weeks. Why? But there should be 4 half-lives, and but T half of the beta HCG is around 36 to 48 hours, and while alpha beta protein is of 4 to 6 days. And why there is pulmonary but toxicity or pulmonary fibrosis after bleomycin? Any clue? The bleomycin metabolized in peripheral tissue by tissue hydrolase is an enzyme, but this enzyme is absent in the lung tissue. So there is
alveolar membrane.
alveolar. And but this will leads to fibrosis, deposition of collagen and interstitial edema. One practical point is of during orchidectomy, what should be.
I want to add that it also then, as we say, the results in a clinical picture which is similar to hyaline membrane disease to Tumour. So it's a type of a pulmonary interstitial pulmonary lung disease. Hyaline membranes deposit to inside the other cells.
Right. So Nachiket is saying that this is very similar to hyaline membrane disease in the children. Correct. These are very important points which may be asked in your exam anytime. So anything else? Yes. Bolo.
During orchidectomy, what should we non-absorbable
All right. So few practical points regarding surgeries, like if you are suspecting a tumor, how to proceed. We know all there is a Shevasu's maneuver where by putting a soft clamp on the cord and then opening of the testis, we see if there is a tumor. We'll go ahead with radical orchidectomy. Otherwise, we will not, or we can send the biopsy for frozen section and then go ahead. And secondly, the suture that you put on a cord is usually a non-absorbable suture. And sometimes you will keep the suture long, because once, if you want to do a retroperitoneal lymph node dissection, you need to remove all these rest of the cord, and also so that you come to know about that. And anything else? CT of the CT abdomen pelvis has to be done once you diagnose a testicular tumor, before even doing a radical orchidectomy. Ideally, I think that should be the chest X-ray, CT abdomen and pelvis, and tumor markers. They have to be as an initial evaluation of all these patients. Yes.
If there is a commitment for it, should we go for
No. If only in case of suspected, if there is a testicular tumor with a retroperitoneal lymph nodes enlarged, then definitely there is no point in doing it. You could go ahead with radical orchidectomy.
One of the disadvantages of doing a post-operative CT is that if you have any leakage of the cord, and if a retroperitoneal hematoma seeps in the retroperitoneum, then assessment of the retroperitoneum becomes difficult. So that's why,
Exactly. Dr. Nachiket has rightly said why it should not be done post-operatively is that if by any chance there is a seepage of blood from the cord side and it produces a hematoma, it will give a kind of an artifact on CT scan that it might mimic as a tumor also. So ideally, it should be done in the initial evaluation. And then about the markers, as he said, should be done at 4 weeks. And the staging, the risk stratification, which we do, is usually done for the markers on the first day of starting the chemotherapy. So day 1 of starting the chemotherapy, what is the level of markers? That will decide the risk stratification, which again depends upon the markers also, right? So this is important. I think, yes, go ahead.
So we should have testicular tumor with the contralateral slightly smaller size testis around 2.5 cm. We should be go for contralateral biopsy, or we should avoid it.
See, if you do not find any tumor by scrotal ultrasound or physical examination on the contralateral side, only if the size is slightly less, that will not tell you to do a bilateral orchidectomy, bilateral radical. Only in case when, but definitely the patients who have atrophied testis, they have a more chance of developing testicular tumor. They are more at risk. So you need to follow up these patients but if you find that, yes, there is a doubtful lesion, there may be, you can do a FNAC of the other side or a biopsy while doing a radical orchidectomy if you have any doubt.
FNAC would, we discussed this previously. FNAC is safe in a testicular tumor. So they shouldn't have in mind that you should not violate the scrotum because FNAC is not a violation of the scrotum. So if you think that there is a testicular tumor on the opposite side, it's always safe to do FNAC. But yes, if you want to do a biopsy, then in 1 inch you can see.
Right. So on the other side, you may do FNAC, but still we do not do FNAC for diagnosing a testicular tumor. So if you find there is a testicular mass, still we would not like to do FNAC to diagnose because it could be inconclusive also. So straight away, go ahead and do a radical orchidectomy if it is a clear-cut testicular tumor. If you are doubt, do a Chevalier maneuver and send it for frozen section biopsy. Anything else? Thank you. Thank you, all of you. Thanks, all residents, faculty members, and all those who might have joined us today. Thanks. We wrap up the session now and have a good day. Just close.